Good evening. This is a presentation of a case study. A brief description of the case study. The case study is about a young man who is 20 years old by the name of Gregory Baker. Mr. Gregory Baker is an African American young man who had been presented with bizarre behaviors in school and at home over the past year with evidences of delusions, hallucinations, and grossly disorganized behavior with diminished emotional expression. Mr. Baker, who has been successful academically as a teenager, has recently been suspended from college due to poor attendance. At home, Mr. Baker, for several months, had been observed to have quit seeing his friends and laying in bed staring at the ceiling, or standing and waving his arms on the rooftop as if conducting a symphony. Mr. Baker is also observed mumbling to himself and appeared preoccupied with a girl called Anne under the notion that they are engaged while not dating. According to Mr. Baker's family, he has no history of drug or alcohol use, and Mr. Baker had denied depression and has no disturbance in sleep or appetite. Mr. Baker had never been seen by a psychiatrist or had any prior psychiatric hospitalizations. When brought to the hospital, assessment of Mr. Baker found Mr. Baker being constricted, guarded, inattentive, and preoccupied. Mr. Baker was also paranoid, grandiose, with romantic delusions, having poor insight and judgment, and Mr. Baker has a family history of mental illness traced to his grandmother and mother. From the information of the case study, Mr. Baker meets the diagnosis of schizophrenia first episode acute phase. This diagnosis is based on the rationale that Mr. Baker meets the diagnosis, the criteria of delusions, from having said that he was a joker and he was looking for Batman. He was also increasingly preoccupied with a female friend, insisting to his family that he was engaged with that female friend, and he felt liberated and in tune with music when he was standing on the roof, and that he didn't mind staying in the hospital, believing that Anne will probably be with him when he was there. Mr. Baker also fulfills criteria A2 of having hallucinations, as evidenced by the recurrent mumbling to himself. He also fulfills the criteria A4 of having grossly disorganized behavior, walking into the classroom shouting, standing on top of the roof of their home, waving his arms as if he was conducting a symphony. Mr. Baker also fulfills criteria A5 of negative symptoms when he was observed rarely speaking, spending most of his time laying in bed staring at the ceiling, and was not speaking while he appeared angry. Mr. Baker meets the B criteria of having decreased level of functioning from the evidence that he had much academic success as a teenager but had been suspended from college because of lack of attendance. He had also quit seeing his friends. Mr. Baker meets criteria C from the continuous signs of disturbance for at least 6 months, as evidenced by the report that his behavior had become increasingly odd during the past year, and had been suspended from school several months prior. Mr. Baker meets the criteria D for having been ruled out of having schizoaffective disorder or any depressive or bipolar disorder with psychotic features, and there was also no report of any kind of presence of major depressive or manic episodes that had occurred. Mr. Baker meets the criteria E of the disturbance not being attributed to any kind of physiological effects of substance use or medical condition. His family had reported that they had not known him of using any kind of substance or alcohol. There was also a report of no disturbance in his sleep or appetite. Mr. Baker meets the criteria of F of not having any history of autism spectrum disorder or communication disorder. Based on his behavior of becoming increasingly odd during the past year and his not having seen a psychiatrist or having any prior psychiatric hospitalization, Mr. Baker meets the evidence to support the diagnosis of schizophrenia of first episode, currently in acute episode. Examination in the emergency room also supports the diagnosis of schizophrenia for Mr. Baker from the observation that he was constricted, guarded, inattentive, and preoccupied. He was paranoid, grandiose, with romantic delusions. He appeared to be internally preoccupied, although he denied hallucinations. He was also paranoid when he loudly insisted that all of the hospital's food was poisoned. Mr. Baker also denied depression and had no disturbance in his sleep or appetite. Mr. Baker was seen to have poor insight and judgment and was positive for mental illness in his family history. Evidence-based treatment plan would be the use of antipsychotic medication with an integration of psychosocial interventions such as individual therapy, social skills training, family therapy, vocational rehabilitation, and supported employment. Mr. Baker will also benefit from a referral to a coordinated specialty care program. Medication used for the treatment of schizophrenia includes second-generation antipsychotics and first-generation antipsychotics. These medications may be prescribed based on careful assessment and evaluation of Mr. Baker in order for the medication to meet the need and have a positive outcome. Certain types of psychotherapy or psychological interventions may also be prescribed or recommended to Mr. Baker, and these include cognitive behavioral therapy, supportive counseling, psychoeducation, family intervention, social skill training, ACT therapy, TORCH therapy, mindfulness cognitive remediation, individual multimodal psychotherapy, cognitive therapy for command hallucination, reasoning training, mindfulness, metacognitive therapy, art group therapy, occupational therapy, and psychodynamic interpersonal therapy. Mr. Baker will also benefit from coordinated specialty care which is a type of program to address the needs of people experiencing first episode psychosis or first episode schizophrenia for the purpose of fostering recovery and preventing disability. Coordinated specialty care program is comprehensive in nature and managed by a team of specialists and encompasses services such as case management, counseling, peer support, supported employment and education, medication management, cognitive and behavioral-oriented individual and group psychotherapy, as well as family support and education.